Okay, you may start. Good afternoon. So welcome to our small group discussion on hypertensive disorders in pregnancy, one of the common obstetric emergencies or obstetric cases that you will see and manage when you become clerks and interns. Okay, so you may start.
So our topic is hypertensive disorders in pregnancy. So hypertensive disorders, they complicate 5 to 10% of all pregnancies, and together they're one member of the deadly triad along with hemorrhage and infection that contributes greatly to maternal morbidity and mortality. Of these disorders, the preeclampsia syndrome, either alone or superimposed on chronic hypertension, is the most dangerous. There are four types of hypertensive disease. There are gestational hypertension, preeclampsia, and eclampsia syndrome, chronic hypertension of any etiology, and preeclampsia superimposed on chronic hypertension. So for the diagnosis of hypertensive disorders, it is diagnosed empirically when appropriately taken blood pressure would exceed 140 millimeter mmHg systolic or 90 mmHg diastolic. Previously, incremental increases of 30 mmHg systolic or 15 mmHg diastolic from the mid-pregnancy blood pressure values had also been used as one of the diagnostic criteria, even when absolute values were below 140 over 90 mmHg. Women who have rise in pressure of 30 mmHg systolic or 15 mmHg diastolic should be observed more closely because eclamptic seizures develop in some of these women whose blood pressures have stayed below 140 over 90 mmHg. A sudden rise in mean arterial pressure later in pregnancy, which is also known as delta hypertension, may also signify preeclampsia even if blood pressure is below 140 over 90 mmHg. So the diagnostic criteria for pregnancy-associated hypertensions are one of them for gestational hypertension. It is if the BP is above 140 over 90 mmHg after 20 weeks in previously normotensive women. And for preeclampsia hypertension, if the values of proteinuria are above or equal to 300 mg over 24 hours, or protein creatinine ratio above or equal to 0.3, or dipstick 1 plus persistent, or when platelets are below 100,000, or in case of renal insufficiency in which the creatinine is above 1.5 mg deciliter or doubling of baseline, and also liver involvement when the serum transaminase levels are twice the normal values, and also other symptoms like cerebral symptoms including headache, visual disturbances, or convulsions, and also pulmonary edema. So first is gestational hypertension. This diagnosis is made in women whose blood pressures reach 140 over 90 mmHg or greater for the first time after mid-pregnancy, but in whom proteinuria is not identified. Almost half of these women subsequently develop preeclampsia syndrome, which includes findings such as headaches or epigastric pain, proteinuria, and thrombocytopenia. Even so, when the blood pressure increases appreciably, it is dangerous to both the mother and the fetus to ignore this rise only because proteinuria has not yet developed. Gestational hypertension is reclassified as transient hypertension if evidence for preeclampsia does not develop and the blood pressure returns to normal by 12 weeks postpartum. Preeclampsia syndrome is described as the pregnancy-specific syndrome that can affect virtually every organ system. And although preeclampsia is more than simply just gestational hypertension with proteinuria, appearance of proteinuria remains an important diagnostic criterion. So proteinuria is an objective marker and reflects the system-wide endothelial leak, which characterizes the preeclampsia syndrome. Abnormal protein excretion is arbitrarily defined by 24-hour urinary excretion exceeding 300 milligram, a urine protein creatinine ratio greater or equal to 0.3, or persistent 30 milligram per deciliter 1 plus dipstick protein in positive random urine samples. Evidence of multi-organ involvement would include thrombocytopenia, renal dysfunction, hepatocellular necrosis, liver dysfunction, CNS perturbations, or pulmonary edema. So the indications of severity of gestational hypertensive disorders. For the diastolic, it is non-severe if it's below 110 mmHg. If it's severe, it is above and equal to 110 mmHg. For the systolic, if it's below 160 mmHg, it's non-severe. And if it is above or equal to 160 mmHg, it is considered severe. For the proteinuria, for both non-severe and severe, it's none to positive. And for headaches, it is present for severe, along with visual disturbances, upper abdominal pain, oliguria, convulsion, and the serum creatinine for severe is elevated, where it is normal for non-severe. Thrombocytopenia is absent in non-severe, where it is present in severe. Serum transaminase elevation is minimal in non-severe, and it is marked in case of severe. Fetal growth restriction is absent for non-severe and obvious in severe, and pulmonary edema is absent in non-severe and present in severe. Eclampsia, it is hypertension in pregnancy with proteinuria along with convulsions or the occurrence of grand mal seizures in a patient with preeclampsia. Generalized seizures may appear before, during, or after labor or 1 week postpartum. In a woman with preeclampsia, a convulsion that cannot be attributed to a cause is termed eclampsia. The seizures are generalized and may appear before, during, or after labor, and the proportion who do not develop seizures until after 48 hours postpartum approximates to 10%. Chronic hypertension is elevation of blood pressure that antecedes pregnancy or persists longer than 12 weeks postpartum. Hypertension is present even before pregnancy, and also it is diagnosed on pregnant women who are taking antihypertensives before conception. It is considered mild when the blood pressure is above 140/90, or severe when it is above 180/110. Preeclampsia superimposed on chronic hypertension. Regardless of its cause, any chronic hypertensive disorders predisposes a woman to develop superimposed preeclampsia syndrome. Chronic underlying hypertension is diagnosed in women with documented blood pressures greater or equal to 140/90 mmHg before pregnancy or before 20 weeks gestation, or both. Hypertensive disorders would create difficult problems with diagnosis and management in women who are not first seen until after mid-pregnancy. This is due to blood pressure. This is because the blood pressure normally decreases during the second and early third trimesters in both normotensive and chronically hypertensive women.
So the HELLP syndrome. So it's a pregnancy complication that affects both the blood and the liver. It antecedes pregnancy or persists postpartum with associated signs and symptoms of preeclampsia. New onset proteinuria in a woman with hypertension before 20 weeks gestation, plus sudden increase in hypertension, or the development of the HELLP syndrome. So the HELLP syndrome is used to describe preeclampsia in association with hemolytic anemia, elevated liver enzymes, low platelet count. So according to the Tennessee classes, the hemolysis means abnormal peripheral smear total bilirubin will be greater than 1.2 milligram per deciliter. Elevated liver enzymes, in that alanine aminotransferase, will be greater than 70 international units per liter. Lactate dehydrogenase, or LDH, will be greater than 600 international units per liter, and low platelet count, which will be less than 100,000 platelets. But according to the Mississippi classification, there are 3 classes: class 1, class 2, and class 3. In class 1, it's considered as severe, the platelets will be less than 50,000. And class 2 will be considered as moderate, where the platelet count will be from 50,000 to 100,000. And class 3, which is mild, the platelet counts will be 100,000 to 150,000. Then the incidence and the risk factors for the hypertensive disorders in the pregnancy. For young and early parents, women are particularly vulnerable to developing preeclampsia, whereas the older women are at greater risk for chronic hypertension with superimposed preeclampsia. The incidence is markedly influenced by race and ethnicity. Higher incidence is there in African American women. Other factors include environmental, socioeconomic, and even seasonal influences. Then other risk factors are multifetal gestation, obesity, maternal age, hyperhomocystinemia, and metabolic syndromes. Women with preeclampsia in the first pregnancy are at greater risk in second pregnancy compared with women normotensive during their first pregnancy. Etiopathogenesis. So it's likely to develop in women with the following characteristics: who are exposed to chronic villi for the first time, which means the primary or the newly pregnant women, and are exposed to superabundance of chronic villi as with twins or hydatiform mole, as in the risk factors. If it is a multifetal pregnancy, there is a high chance that the patient can develop the hypertension, have pre-existing conditions of endothelial cell activation or inflammation such as diabetes or renal or cardiovascular disease, and who are genetically predisposed to hypertension developing during pregnancies. A fetus is not a requisite for preeclampsia to develop. Presence of chronic villi is essential, but need not be intrauterine. Preeclampsia syndrome is characterized by abnormalities that result in vascular endothelial damage with resultant vasospasm, transudation of plasma, and ischemic and thrombotic sequelae. The etiology, an imposing number of mechanisms have been proposed to cause the eclampsia. One is placental implantation with abnormal trophoblastic invasion of uterine vessels. Then the second is immunological maladaptive tolerance between maternal, paternal, and fetal issues. Then third is maternal maladaptation to cardiovascular or inflammatory changes of normal pregnancy. And the fourth is genetic factors, inherited predisposing genes, and epigenetic influences. And most likely, if the first degree relative have a history of hypertension, it's more likely that the pregnant women also have high chance of developing the hypertension. So the first one, abnormal trophoblastic invasion. What happens in there is normal implantation is characterized by extensive remodeling of the spiral arterioles within the decidua basalis. But in this case, endovascular trophoblasts replace the vascular endothelial and muscular linings to enlarge the vessel diameter. In case of preeclampsia, there may be incomplete trophoblastic invasion. So the deeper the myometrial arterioles do not lose their endothelial lining and musculoelastic tissue, and their mean external diameter is only half that of corresponding vessels in normal placentas. So that there will be constriction and the peripheral vascular resistance will be increased, which leads to hypertension. In general, the magnitude of the defective trophoblastic invasion is thought to correlate with the severity of the hypertensive disorder. So this is an example of the normal and the one with the preeclampsia. So you can see that the diameter of the spiral arteries are reduced, and this increases the peripheral vascular resistance. Immunological factors, loss of maternal immune tolerance to paternally derived placental and fetal antigens. Preeclampsia may be an immune-mediated disorder. For example, risk of preeclampsia is appreciably enhanced in circumstances in which formation of blocking antibodies to placental antigenic sites might be impaired, which means that the first pregnancy would carry a higher risk. In women destined to be preeclamptic, extravillous trophoblasts early in pregnancy express reduced amounts of immunosuppressive non-classic HLH. Endothelial cell activation. Anti-angiogenic and metabolic factors and other inflammatory mediators are thought to provoke endothelial cell injury. Endothelial cell dysfunction may result from an extreme activated state of leukocytes in the maternal circulation. Cytokines such as tumor necrosis factor and the interleukins may contribute to the oxidative stress associated with preeclampsia. Activation of microvascular coagulation manifests by thrombocytopenia, and increased capillary permeability manifests by edema and proteinuria. So that is patients may, the hypertensive patients may present with the proteinuria and the edema, which we can see by pitching edema, can test it. And the genetic factors, they are multifactorial, polygenic disorder. So there will be 20 to 40% of chances for the daughters to develop preeclampsia or hypertensive disorders if the mother have preeclampsia in her pregnancy. and 11 to 37% of chances when the sisters are getting preeclampsia, so that the other sister may also get the preeclampsia. Then 20 to 40% chance in case of multiparent pregnancies. Hereditary predisposition of for preeclampsia likely is the result of interactions of literally hundreds of inherited genes, both maternal and paternal, that control myriad enzymatic and metabolic functions throughout every organ system.
In pathophysiology, the endothelial activation causes vascular constrictions with increased resistance and subsequent hypertension. Endothelial cell damage causes interstitial leakage through which blood constituents, including platelets and fibrinogens, are deposited subendothelially. With diminished blood flow because of maldisruption, ischemia of the surrounding tissues can lead to the necrosis, hemorrhage, and other end organ disturbances characteristic of the syndrome. Endothelial cell injury has become the centerpiece in the contemporary understanding of preeclampsia pathogenesis. Protein factors like placenta are secreted in the maternal circulation and provoke activation and dysfunction of the vascular endothelium. Many of the features of the clinical syndrome of preeclampsia are thought to result from these widespread endothelial cell changes. Intact endothelium has anticoagulant properties, and endothelial cells blunt the responses of vascular smooth muscles to agonist by releasing nitric oxide. Damaged or activated endothelial cells may produce less nitric oxide and secrete substances that promote coagulation and increase sensitivity to vasopressors. Severe disruption of normal cardiovascular function are common with preeclampsia syndrome due to the increased cardiac afterload use of hypertension, cardiac preload, which is affected negatively by pathologically diminished hypervolemia of pregnancy and is increased by intravenous crystalloids or ontic solutions. Endothelial activations with intraendothelial extravasations of intravascular fluid into the extracellular space and importantly into the lungs. With the clinical onset of preeclampsia, cardiac output declines. Due to increased peripheral resistance, pulmonary edema may develop despite normal ventricular function because of an alveolar endothelial epithelial leak. Aggressive fluid administration substantially elevates normal left-sided filling pressures and increases physiologically normal cardiac output to hyperdynamic levels. Positive hemoconcentration results from generalized vasoconstrictions that follow endothelial activation and release of plasma into the interstitial space because of increased permeability, lower blood volume than normal pregnant women. Women with eclampsia are undoubtedly sensitive to vigorous fluid therapy administered in an attempt to expand the contracted blood volume to normal pregnancy levels. And also women with eclampsia are sensitive to amounts of blood loss at delivery that are considered normal for a normotensive woman. Thrombocytopenia. Overt thrombocytopenia is platelet count which is less than 100,000 microliters per microliters indicates severe disease. The lower the platelet count, the higher the rate of maternal and fetal morbidity and mortality. In most cases, delivery is advisable because thrombocytopenia usually continues to worsen. After delivery, the platelet count may continue to decline for the first day or so to increase progressively to reach a normal level within 3 to 5 days. Hemolysis. Hemolysis manifested by elevated serum lactate dehydrogenase levels and decreased hepatoglobin levels. Other evidences comes from schizocytosis, spherocytosis, and reticulocytosis in peripheral blood. Results from microangiopathic hemolysis caused by endothelial disruptions with platelet adherence and fibrin deposition. Erythrocytic membrane changes, increase adhesiveness, and aggravations may also prompt an hypocoagulable state. In women with severe preeclampsia, the volume of extracellular fluid manifests as edema, greater than that in normal pregnant women. In the mechanism responsible for pathological fluid retention is thought to be endothelial injury. Plasma oncotic pressure creates a filtration imbalance and further displaces intravascular fluid into the surrounding interstitium. Following an eclamptic convulsions, the serum pH and bicarbonate concentrations are lowered due to lactic acidosis, and compensatory respiratory losses of carbon dioxide. Renal perfusion and glomerular filtration are reduced. Decreased glomerular filtration may result from reduced plasma volume. Most of the decrement, however, inform increased renal afferent arterial resistance that may be elevated up to fivefold oliguria. Intensive intravenous fluid therapy is not indicated as treatment for preeclamptic women with oliguria, as rapid infusions may cause clinically apparent pulmonary edema. Severe preeclampsia may manifest with moderate to severe right upper quadrant or mid-epigastric pain and tenderness, secondary to hepatocellular infarct, hemorrhagic necrosis, or rarely liver hematomas. Severe preeclampsia may manifest with headache and scotomata and are thought to arise from cerebrovascular hyperperfusions that has predilection from occipital lobes. 20 to 30% have visual changes preceding preeclamptic convulsions. Headaches may be mild to severe and do not usually respond to traditional analgesia, but they do improve after magnesium sulfate infusion is initiated. Blindness is rare with preeclampsia alone, but it complicates eclamptic convulsions in up to 15% of women, usually improve with magnesium sulfate therapy and or lowered blood pressure. Blindness from retinal lesions is caused either by serious retinal detachment or rarely by retinal infractions, which is termed Buster's retinopathy. Serious retinal detachment is usually unilateral and seldom uses total visual loss. Generalized cerebral edema may develop and is usually manifested by mental status changes that vary from confusions to coma. It is very dangerous because fetal transtentorial herniations may occur. Predictions and prevention of vascular resistance testing. Proactive precursor tests. 3 tests have been extensively evaluated to access the blood pressure rise in the response to a stimulus. First one is the rollover test. It measures the hypertensive response in women at 28 to 32 weeks who are resting in the left lateral dubicus position and then roll over to the supine position. Increased blood pressure signifies a positive test. Next is isometric exercise test. Employs the same principle by squeezing a handball. Next is angiotensin II infusion test. Is performed by giving incrementally increased doses intravenously and the hypertensive response is qualified. Uterine artery Doppler isometry. Faulty thromboplastic invasions of the spiral arteries results in diminished placenta perfusions and upstream increased uterine artery resistance. Increased uterine artery volumetry determined by Doppler ultrasound in the first 2 trimesters should provide indirect evidence to this process and thus severe as a predictive test of preeclampsia. Increased flow resistance results in an abnormal waveform represented by exaggerated diastolic notch. Methods to prevent preeclampsia. First one is the dietary manipulations, advising low salt diet, calcium or fish oil supplements, daily exercise like physical activity and stretching, cardiovascular drugs used like diuretics, antihypertensive drugs, and next is antioxidants like ascorbic acid, vitamin C, alpha tocopherol, which is vitamin E and vitamin D, antithrombotic drugs like low dose of aspirin in combination of dipyridamole, or aspirin plus heparin or aspirin plus ketaseril.
What's your source of that paper?
Ma'am?
What's the source of your table?
It's
from the book.
Williams book.
It's from Williams.
Yes, book.
Okay, go ahead.
Management objectives: to reduce severity, prevent progression of the disease, to prevent convulsions, to control severe hypertension, to deliver the mother or fetus at the optimum time and with the least trauma to both mother and infants, to detect the appropriate end organ damage, to complete resort health of the mother. Home health care allowed for gestational hypertension and mild preeclampsia with age of gestation of less than 34 weeks, sedentary activity for most part of the day, home BP and urine protein monitoring, patients instructed in detail about reporting symptoms and fetal kick counts. Patients should be evaluated by physician for maternal and fetal well-being at least once weekly. Weekly checkup on patients on home health care. BP monitoring at each visit, platelet count and liver enzymes, non-stress test in the mainstay of fetal assessment, fetal growth assessment every 2 to 3 weeks, magnesium sulfate, antihypertensive meds, low dose of aspirin and high dose of calcium are not recommended. Fetal assessment test, non-stress test ideally done daily, biophysical profile with amniotic fluid intakes at least twice weekly, umbilical artery Doppler once weekly, fetal growth assessment using abdominal circumference done every 2 to 3 weeks, antenatal corticosteroids given between 24 to 34 weeks, age of gestation to enhance lung maturity, even up to 36 weeks. Recommended regimens are betamethasone 12 mg 24 hours for 2 doses, dexamethasone 6 mg for 12 hours for 24 doses. Timing of delivery will depend on fetal gestational age, antepartum fetal surveillance test, maternal BP, amount of proteinuria, and maternal symptoms as labor, rupture of membrane, vaginal bleeding, and other factors indicating delivery. Admit severe preeclampsia. Greater than 34 weeks of gestation. Ensure maternal safety and delivery is exhibited. Less than 34 weeks of gestation, expectant management is clearly acceptable when severe preeclampsia by proteinuria and when severe eclampsia on basis of IUGR alone with good fetal testing, and when clear preeclampsia by BP criterion.
Management algorithm for severe preeclampsia greater than 34 weeks. Severe preeclampsia, admit, maternal and fetal assessment, consider MGSO4, treat dangerous hypertension. Contraindications are persistent symptoms of severe hypertension, eclampsia, pulmonary edema, HELLP syndrome, significant renal dysfunction, coagulopathy, abruption, previable fetus, fetal compromise. If these are present, you can continue to deliver. If they are absent, initial 24 to 48 hours observation is done. Corticosteroids for lung maturation, frequent evaluation, vital signs and urine output, daily lab evaluation for HELLP syndrome. And again, if it's absent, then ongoing inpatient management, daily maternal assessment, serial lab evaluation of renal function, and for HELLP syndrome, daily fetal assessment and evaluation of serial growth and amniotic fluid volume. Deliver at 34 weeks. Indications for delivery in severe preeclampsia, corticosteroid therapy for lung maturation and delivery after maternal stabilization. Uncontrolled severe hypertension, eclampsia, pulmonary edema, placental abruption, disseminated intravascular coagulation, non-reassuring fetal status, fetal demise. Corticosteroid therapy for lung maturation. Delay delivery 48 hours if possible. Preterm ruptured membranes or labor, thrombocytopenia less than 1 lakh. Hepatic transaminase levels twice upper limit of normal. Fetal growth restriction, oligohydramnios, reversed end diastolic Doppler flow in umbilical artery, worsening renal dysfunction.
When will you say that it is uncontrolled hypertension?
Sorry, Doc?
When will you say that this patient has uncontrolled hypertension? What are your armamentarium for BP control? What's the first line? What are the oral drugs that we usually give?
Labetalol, doc.
Okay, labetalol is one. Although if you're practicing in the Philippines, what's the first drug that we give, oral agent?
Methyl dopa.
Okay, methyl dopa. What is the maximum dose of your methyl dopa?
3 gram, doc.
250 to
3
500
grams.
mg.
3 grams. So the formulation is 250. So you could give up to 4 tablets 3 times a day. If your hypertension cannot be controlled by your methyl dopa, what would you give next?
Hydrazolam, doc.
Okay. How do you give your hydralazine?
$50 to 300 mg per day, doc, divided into 2 to 3 doses.
Okay. We usually give 5 milligrams or 10 milligrams. IV push up to 3 times until your BP resolves. If it normalizes, you can stop. And then if it increases again, then you could start the 3 doses again, but not more than 3 doses, right? After your hydralazine, what could you give? And it's still not controlled.
Nifedipine, doc.
Nifedipine, doc.
Nifedipine is oral.
Yes, doc. Oral.
We're already at IV.
Nicardipine, doc.
Okay.
IV form of.
We could give nicardipine drip, Soluset, up to 1 IV, and titrate as needed. Only then could you say that it's uncontrolled hypertension. Okay. What are your other indications? You may continue.
Indications for delivery, maternal indications, persistent severe headache or visual changes, eclampsia, pulmonary edema, epigastric or right upper quadrant pain with AST, ALT greater than 2 times the normal, uncontrolled severe hypertension despite maximum doses of antihypertensive agents, oliguria greater than 1.5 mg, and serum creatinine, persistent platelet count less than 1 lakh, suspected abruption placenta, progressive labor and or rupture of membranes. Fetal indications.
What would produce your epigastric pain?
Stretching of the
Stretching of the
Clisson capsule.
stretching of the Clison's capsule. Okay. What could produce your oliguria? What could cause decreased urine output in your patient?
If there is renal injuries, then it can cause oliguria due to the
Okay, renal
hypertension.
injuries. What else could oliguria be a byproduct of, a side effect of?
Serum creatine.
What else?
Urine output less than 500.
What would decrease your urine output?
Yes, inhibitors.
What?
ACE inhibitors.
ACE inhibitors. What do we give our patients that could decrease urine output? And that is why all patients that would have preeclampsia would have to have Foley catheter inserted upon admission. What among your interventions could cause decreased urine output?
And contraction of intravascular space secondary to vasospasm.
What among your interventions? So meaning it is a side effect of something that you administered to a hypertensive patient.
Aspirin, doc.
Hydrochlorothiazide po.
What?
Hydro-
One answer is aspirin. The other, what's your answer, Roy?
Hydrochlorothiazide, if it is a diuretic, it can cause volume deficit.
Diuretics. If hypertensive, what treatment is essential? What do you give? And if you are to have clinical bedside experience, you know that for all hypertensive patients, you check this. You check the urine output among these other things because you are giving what?
Diuretics, doc.
Diuretics. What is essential to be given in a hypertensive patient? What is the most important drug? Oh, it's a drug that you
Ibuprofen,
give
doc.
to
Angiotensin.
ibuprofen. We don't give ibuprofen to pregnant patients.
ACE inhibitors, doc.
What do we give to pre-eclamptic patients? What is the complication? What is the worst case scenario for a hypertensive patient? What is the thing that we don't want to happen?
Seizures, doc.
Okay, seizures. What do you give to prevent seizures?
Magnesium
Okay,
sulfate,
give
doc.
magnesium
Magnesium
sulfate.
doc.
And your magnesium sulfate, what are the side effects?
Oliguria.
Oliguria. And what are the other side effects of your magnesium sulfate? Okay, oliguria is one. What are the two
Breathing
others?
difficulties,
Okay, respiratory depression, and the other is
confusion, weakness,
what else?
Heart
It's a
disease.
neurological finding.
Any knee jerk stop.
Oh, knee jerks, or that is your decrease.
Reflexes.
Okay, increase or decrease?
Decrease reflexes.
Decrease deep tendon reflexes. Okay, so your magnesium sulfate has a small therapeutic window. Okay, what's the therapeutic window for magnesium sulfate? Okay, you will find it in Williams, the therapeutic dose, and you will find it in Williams when your DTRs decrease, when your urine output decreases, and when your respiratory rate depresses up to a certain level. Okay, if you're gonna leave this hypertensive SGD, at least know magnesium sulfate and its side effects. Okay, such that when you are clerks, you are expected to, when you see a magnesium pre-eclamptic patient, when you monitor at bedside, you monitor the output, you monitor the respiratory rate, and you monitor the deep tendon reflexes. Not saying that you don't monitor anything else, but you pay attention to that primarily because you are giving magnesium sulfate. Is that clear? Continue.
Fetal indications, severe fetal growth restrictions less than 50 percentile, persistent severe oligohydramnios, repetitive late or variable fetal heart rate decelerations, persistent VPS less than 4 evaluations 6 hours apart, umbilical artery Doppler imaging with reverse diastolic blood flow, fetal death. Prevention of convulsions, MgSO4 is a drug of choice. Loading dose of 4 grams slow IV over 5 to 10 minutes and 10 grams deep IM, 5 grams to each buttock, then 5 grams IM every 4 hours until 24 hours postpartum. Loading dose of 4 grams IV followed by IV infusion of 2 grams per hour Incorporate 20 grams MgSO4 4 10 ml ampules of 50% MgSO4 to 1 liter of D5W or NM and infuse IV at a rate of 100 ml per hour. That is 2 grams per hour. Reduce the drip to 1 gram per hour after 24 hours. Precautions to be observed before administration or subsequent doses include urine
See,
output.
it's in your slides.
Urine output greater than 30 ml per hour or 100 ml per 4 hours. Presence of patellar reflexes. Respiratory rate or not less than 12 per minute. Therapeutic level is 4 to 7. And toxic levels 8 to 10 reflexes disappear. 10 to 12 respiratory depression. 12 to 15 respiratory and cardiac paralysis. And greater than 25 it's cardiac arrest. Prevention of convulsions, other available drug, diazepam. Loading dose of 10 mg IV over 2 minutes. Repeated if convulsions reoccur. Followed by infusion of 40 mg in 500 ml NSS for 24 hours. Phenytoin, loading dose of 1 gram slow IV over 20 minutes, followed by succeeding doses of 100 mg every 6 hours for the next 24 hours. Control severe hypertension. Antihypertensive treatment should be started in women with BP greater than 160 by 110 mmHg or at lower degrees of hypertension in the presence of potentially severe disease. Aim BP to be at 140 to 155 mmHg systolic and 90 to 105 mmHg diastolic, or a map of 90. Start at lower doses to avoid hypotension in this intravascularly volume depleted patients. Other antihypertensive medications, methyl-dopa 0.5 to 3.0 grams per day in 2 doses, centrally acting drug. Lobetal 200 to 1200 mg in 2 to 3 doses. Nifedipine 30 to 120, slow release preparation, seldom used and suddenly decreases BP from 180 to 120. Hydralazine 50 to 300 in 2 to 4 doses. Drug of choice mainly acts on pathology as a vasodilator. Beta receptor blockers 50 to 200 into 2 to 4 doses. Hydrochlorothiazide 12.5 to 25, given only when the patient have pulmonary edema. Otherwise, don't give thiazide or diuretics since they are already volume deficits. Drugs for urgent control of BP, hydralazine 5 mg IV or IM, then 5 to 10 mg every 20 minutes. Once BP is controlled, repeat for 3 hours. For infusion, 0.5 to 10, maximum dose 20 or 30. Nifedipine 10 to 30 mg orally, repeat in 45 minutes if needed. Maximum dose is 50. Mode of delivery. Vaginal delivery is generally preferable. Consider the following. Fetal gestation less than 32 weeks. Fetal presentation, fetal condition. Likelihood of success of induction of labor where vaginal prostaglandins will increase the chance of success.
What kind of vaginal delivery?
Assisted.
Assisted vaginal delivery, that's either by outlet forceps extraction or your vacuum delivery. Why do we do that? Why do we do assisted vaginal delivery compared to spontaneous vaginal delivery? What's the rationale behind that practice?
To reduce the time of the second
To
stage.
reduce maternal pressure, which is often increased during the second stage of labor when the mother bears them. Okay, go ahead, continue.
Concerns during delivery, blood loss in delivery, hemoconcentration or lack of normal pregnancy-induced hypervolemia makes pre-eclamptic women less tolerant to even normal blood loss. Analgesia and anesthesia, conduction anesthesia, epidural or spinal, is ideal as it prevents severe hypertension, pulmonary and cerebral edema, intracranial hemorrhage usually seen in tracheal intubations. Postpartum management. Anticonvulsants should be continued for 24 hours. Antihypertensive should be weaned stepwise. BP usually decrease immediately but may rise again after 24 hours. Methyl dopa is not recommended for use of postpartum because of depression side effects. Furosemide should be used with caution.
What do you then recommend as an agent of hypertension for postpartum women? Have you read? What readings have you encountered with regards to hypertensive agents postpartum?
Anti-hypertension drug.
Can you use any? It's like as if the patient did not get pregnant. The baby's not there anymore. Saini, Ravikant, what's your
Yes.
opinion? You could give any? What do you have to consider? Rexon, Activel.
We can't give methyl dopa because a patient might have a postpartum depression.
Yes, you specifically said methyl dopa we do not give. That's why I am asking, what do we give then if we cannot give methyl dopa anymore? Can we give any hypertensive drug? Or if the patient was a chronic hypertensive, I'll just use the drugs that she used before. Rengaraj, Vinotini. Karan, Sadhu. What do you think? A show of hands. Raise your hand. Clerk Russell Raj. You give any?
Methyl dopa.
It's said there you don't give methyl dopa for fear of depression of side effects. The baby, the mother has already delivered. So our baby is already outside. So postpartum hypertensive meds, what will you prescribe?
Also,
Nifedipine,
doc. Nifedipine.
Nifedipine. Okay.
Labetalol,
What
doc.
else?
Hydralazine, labetalol.
Nifedipine, doc.
What do you not prescribe? And why will you not prescribe it? For
To avoid postpartum depression, doc.
okay, for any postpartum patient,
Ma'am, we avoid ACE inhibitors.
okay, we do not give ACE
NSAIDs, doc.
inhibitors.
Yes,
Why?
Can't
because they are
because it
teratogenic.
also
What?
They are
Why
teratogenic.
don't the baby's already delivered? So why are you scared of it being a teratogen?
can't give
So for
NSAIDs because it's also cause the hypertension. Like
okay, you think, okay, baby has delivered, mother is still hypertensive. Okay. So we are looking for the best hypertensive agent? Okay. So you are telling me ACE inhibitors are avoided during postpartum, or at least first weeks. Why do we have to avoid it among postpartum women? So what are the usual activities of a postpartum woman? Breastfeeding. So in any pregnancy disease, after delivery, you look at that management and you will see how the drugs that you will administer to that patient would affect breastfeeding. Would it cross the maternal breast and transfer to the baby through breastfeeding? And you do that for every disease and not just for hypertension. Could the woman take vaccine during pregnancy, a live vaccine, breastfeeding? So those are the questions that you ask. Could be yes, could be no. For diabetic, for renal, could a patient on azathioprine for kidney disease have breastfeeding? So those are supposed to be automatic questions for you, and this is applicable not just for hypertensive patients. You ask, is this medicine one while pregnant? Is this going to affect my pregnancy? So you look at your pregnancy categories, correct? When the patient's already delivered, your next question will be, if I will administer a drug, how will this affect breastfeeding? Those two should be automatic questions among you. Is that clear? And again, another automatic I did not emphasize, when you are at the ER and you look and you see a hypertensive patient, what is the thing that you are not supposed to do? Physical examination. You know that the patient is hypertensive. Sankar Balaji. Okay, while I'm asking for the question, could you open your cameras? Roy, could you have a picture, then send it to me?
Yes. Arvind,
Ravindranath? Okay. Okay, to end it, what do you do? Sorry. What is an absolute no-no for you to do to a hypertensive patient in the emergency room? Anyone? So you've presented with me with theoreticals. What I am asking you are practical and common questions of patients. Doc, my BP is still high. What medicine could I get after delivery? And this practical question is always asked in the wards. And I know if you do this on a hypertensive patient, you will have a repeat rotation by tradition. And what is that? What do you not perform? And it's very much against what we practice in obstetrics because we have trained you that the internal examination is very important. But in a hypertensive patient, you do not perform an internal examination until you have administered your magnesium sulfate. And why is that? Again, context clues. You do not perform an internal examination unless you have given your magnesium sulfate. So what could you induce when you do an internal examination without magnesium sulfate? So if you follow the thought process, you will know the answer. And what is it?
Seizures, doc.
Okay. You may, although in all my, I've been a doctor for 12 years, I haven't seen someone, maybe that will be very traumatic for that doctor. I have never seen someone having a seizure while doing an internal exam. I pray that I will not be one. Okay, what's the other? So there are only 2 contraindications to perform an internal exam among obstetrics. One is your patient is hypertensive. The second is what? When do you not do an IE?
Placenta previa or placenta previa.
Okay, you do not perform an internal exam for patients with documented previa or third trimester bleeding unless you have documentation of the location of the placenta. Okay? So, practical questions. I want you to remember your mag sulfate, your internal examination, and your dosage. Oh, last. When will you reevaluate your hypertension? When do you expect the BP to return to its pre-pregnancy state?
12 weeks postpartum.
After 12 weeks postpartum, some say 6, but your books will say 12, right? So after 12 weeks, you reevaluate. If it becomes normal, okay. If it is still high, then patient has chronic hypertension. And you could just label if patient did not have any proteinuria, just elevated BP. So only then could you label it truly as a gestational hypertension case. Okay? Any? So if there's none, you may leave the call.
Thank you for that.
Thank you,
All
sir.
right.
Thank you, Doc.
Thank you, Doc.
Do we have another SGD? You just inform me, Roy,
Yes,
if there's
we have
another
one.
SGD. All right.